So take a second to stretch and breathe. There we go, I think. So it's the second day. Everybody's a bit more relaxed, I see. More questions. That's good. Oh, no. Sure. Start to... roll up our sleeves a little bit. I wanted to comment a little bit and know about the issue about whether or not CP is going up or down or staying the same, because Linda and I said a little bit different things. I said yesterday it's probably staying the same or going up in preterm, and the indication from her today was that maybe it's going down. And I think we need to be careful a little bit about that, because in terms of the term babies, it may well be sort of going down because the care is getting better. In preterm, it went way up for a long time, and then now it's sort of coming down, but it's still quite a bit higher overall per thousand, I think. I don't know, Linda wants to comment on that, than we see in term babies. And so my hope is that it continues to go down, and certainly with the imaging techniques and some of the things that hopefully we'll point out during this talk, it'll be a little bit better.
If I can say something on that, I think there is also a difference in countries in which there is no really redirection of care, and this is just my personal experience. I don't see really the incidence of CP going down very much. So I think that there is also this factor that might play a role. I mean, no redirection of care means not really CP going down very much.
And certainly in North America, there's, I think, less redirection of care than perhaps in some of the European and developing countries. So it really speaks to how a lot of the data is actually analyzed and how it's looked at, the definitions of CP that people are looking at, and not to confuse the issue, but only to indicate that we need to be careful and sort of be on the same ground and always looking towards how to improve care. I started a little commotion here. Excellent.
I just wanted to say that we also compared our mortality rates when you think about redirection of care.
Yes.
It's quite true that in the Netherlands we are maybe a little bit more liberal. I once was giving a talk, and then somebody stood up in the audience and said, "She's Dutch, they kill them all." It wasn't very pleasant, but it happened to me. And so our mortality is not kind of different, and I think the most important thing is that in our own unit, the cystic PVL, extensive cystic PVL, really went down a lot, and I think that is an important marker. And actually, Hemrick from UCSF pointed out the same, that there was also a decline in cystic PVL, and there was a study from Germany as well, and that's the kind of most important marker, especially of the severe cerebral palsy. If you have got a child with a hemiplegia, it's something entirely different than having a child with a quadriplegia following grade 3 PVL.
Yes, and I think that's true in the Canadian registry, where we're just analyzing the data. The majority of kids are actually in the GFM category in the grades 1 to 3, as opposed to 4 and 5. So I think there's certainly consistency in the fact that the extent of cerebral palsy is getting better over time. Is that fair to say? And perhaps the incidence of cerebral palsy is either not changing, but certainly the severity of cerebral palsy perhaps is getting better. And that leads nicely into, I think, I hope, what I'm going to talk about, and leads off from the question by the gentleman in the second row there, about some simple approaches to therapeutic to therapies about perinatal brain injury. And so this talk is not going to, tell you very much, but I want to emphasize this because I'm a very simple-minded guy. And some of the things that we see in the literature now and some of the experimentation that's going on around the world is certainly fabulous, but we can't forget to do some of the ABCs that we should be doing in our kids who are ultimately very very sick and can really make a big difference. And this was really emphasized to me by Shu Lee, who some of you may know, who's a neonatologist in Canada and developed the Canadian Neonatal Network. And he compared our nurseries across the country, because we have, Canada's a big country, but we only have 16 nurseries, certainly 16 tertiary care nurseries. And we like to believe our care is pretty much the same across the country. And in fact, it sort of is, but there was quite a bit of variability in mortality and morbidity rates between the countries, or between the various units. But when he normalized data, he's a MBA and a fancy epidemiologist, and so he formulated a way of kind of normalizing the data whereby he could mathematically figure out if all the units treated the babies the same, in fact, the mortality and morbidity was the same. So these little things about temperature and other things that I'll talk about in the next few minutes are, I hope, if you take anything away at all from this talk, that they're important and that we should not neglect them. So quite simplistically, I'm just going to review some of the contributors to perinatal brain injury, which is a bit of a lead-off from my talk yesterday. People hear me? That's good. You can hear me, right? I've got a loud voice. We're good.
Yeah. It's your job. You can control it.
Yeah. No,
It's better if you come here and
okay.
speak here.
Is that better? Okay. Thank you. So we're going to just review some of the contributions to perinatal brain injury and discuss why they occur and some of the simple and very doable, I think, approaches to this. So you'll all remember this very basic slide, which is very complicated. Things start with hypoxia, ischemia, or infection, or any form of brain injury. It usually leads to some degree of energy failure, and then it creates this huge cycle of events that occurs. And at each point in time, there can certainly be aspects of interruption. And we remember this slide too, and this has been emphasized many, many times already, that there's a whole spectrum of injury from all the way from white matter injury, oftentimes in the premature infant up to 32 and sometimes 36 weeks of age, to gray matter injury that Linda very nicely outlined in her last talk. Perinatal stroke can occur obviously either in utero as a presumed perinatal stroke, in the premature infant, or around the time of birth. But many things are consistent in terms of physiologic functioning that can occur in these babies when they enter into the nursery or onto the wards. And they're all really very common. And they all provide complications or contributions to prematurity or term hypoxia and or ischemia. And they're all things that are very familiar to us. Thermoregulation is obviously something that's been very prominent, and I'll speak more about hypothermia tomorrow, but today I want to emphasize just the thermoregulation aspect of things in hyperthermia. Seizures are huge contributors to injury, in my opinion, and certainly I've become a convert over the years that I've been practicing in terms of whether or not one should look at these seriously and whether or not they should be treated. Hypoglycemia is not something to be ignored. Those remains controversial in terms of its contribution to injury. Hyper or hypocapnia is something that was referred to in carbon dioxide and was pointed out by Bob Vanucci in some early studies and is now really becoming something that we need to be aware of. Humidity is something that we tend to neglect entirely in our nursery and certainly I think in many others. And then, of course, infection and sepsis. So my question is, are there some simple approaches to the treatment or prevention of these events that will improve outcome and that we, in fact, can control? As each one of these we can control to greater or lesser degrees and are things, in my opinion, that we need to sort of pay very direct attention to. And oftentimes, at least I find in our nurseries, our residents and our fellows, they're all about the numbers on the machine and they're all about let's do an MRI or an ultrasound and they're all about what's the next fancy test. And they tend to neglect if the baby's breathing well or if the baby's hot or if the baby's too cold, or if the baby's losing fluid, or is getting adequate nutrition, or many of those things that are really, I think, quite doable. So I guess I want to emphasize that, and hopefully that's the walkaway message. So this would be just a simple case, a late preterm infant, spontaneous rupture of membranes with meconium. Mom has contractions with variable decelerations, and then near the end of pregnancy has some fetal heart rate variability and a deep prolonged deceleration, what would be referred to as a sort of a sentinel event, and goes for emergency cesarean section. And not surprisingly, we see a baby who has diffuse evidence of ischemic injury to the seen on diffusion-weighted imaging here in the posterior circulation, posterior regions, the middle circulation, as well as the deep gray matter circulation. So this is a baby who's really very sick, who we would expect to not do very well, and who can oftentimes have difficulties with thermoregulation and control, and probably would go nowadays to undergo hypothermic cooling. But we need to be aware that babies like this will also develop a number of those other complications, and one of them is actually hyperthermia. So in our work in our lab, we've looked at some of these aspects of things, and we wanted to look at whether or not cooling before or heating before one undergoes intensive care does anything bad, because people were, as we look at cooling, we need to figure out whether about timing and when is the appropriate time to cool or heat or maintain thermoregulation. So we took our 7-day-old model of ischemic injury that Bob Vannucci developed, and we decided to look at thermoregulation under several different circumstances. One was cooling, where the baby or the little rat pup, which would be a roughly preterm equivalent, was maintained in a water bath at either 28 degrees, which is equivalent to a core temperature of about 32, all the way up to 39 degrees, which is a core equivalent of about 40 degrees. So all the way from hypothermia to normothermia and to hyperthermia. And we did that under several different circumstances. One was we exposed them to that kind of temperature before the onset of the lesion for 3 one-hour periods, for 3 hours, 24 hours before the time, and then immediately before the injury occurred. And what we found was a couple of things. One was, if we cooled them before the actual injury, so if you think of a preterm baby who's looking well but who has multiple episodes of apnea or bradycardia or ischemia, and you cool them before the injuries, what we found was that the mortality rate actually significantly increased if you cooled them before. If, on the other hand, you heat them beforehand, we found that they actually did a little bit better in terms of their overall score. And that goes along with what we, predisposing the babies to heat can often actually improve things. So the point of this slide is really not so much about, well, it is about the fact that thermoregulation is important, but it's also to point out that simply saying cooling babies is not adequate enough. We need to be clear about when we're doing it, under what circumstances we're doing it, and why we're doing it. It's not just about cooling, it's about the whole process of timing and duration. So in this particular experiment, and I don't think this has been done in humans, probably for good reasons, if you cool beforehand, probably not such a good idea, particularly in a preterm infant. On the other hand, if they're a little bit warm beforehand, that may not be entirely bad, though I'm certainly not recommending that, more in terms of normothermia. And that's important because there's a lot of information now coming out about wrapping preterm babies, as you all know, to reduce loss of fluids, etc., and some of your nurseries may well be doing that. And I'm just suggesting that we not be glib about it, and that we pay attention to why we're doing it. So this little baby is also going to undergo seizures. There's pretty much no doubt about that. Almost 100% of babies with sort of a SARNAT 2 or 3 will have seizures just by definition. They'll be cooled, and that may have some effect on them, and I'll show you that in a minute. But we wanted to know a number of years ago, as Roberta pointed out, whether or not seizures per se will cause injury, and whether or not seizures, in addition to hypoxia ischemia, will also cause injury. So we published this back in 2004. So we took, again, some baby rat pups at around P10, which is a roughly term equivalent rat pup, and we induced seizures using canic acid. And what we found was that these babies who underwent seizures actually became hyperthermic while they were having the seizure. So this is a temperature graph over time. These are the babies who are having seizures for quite a prolonged period of time, and their temperature went up about 1 degree to 1.5 degrees more than those baby rat pups who did not have injury. And this is what their EEGs looked like. This is a rat not on drugs. This is a rat on drugs and canic acid, and showing multiple seizures during the time. So we wanted to do that in order to confirm that in fact they were having electrocortical seizures and not just clinical seizures, that we could actually see them. And this is what a rat pup having neonatal seizures for as long as 4 hours, so continuous electrographic seizures for 4 hours, which in the life of a rat is a long time, let me tell you. It's almost a day. And what we found, and this is a normal rat pup without any ischemia, without anything like that, what we found was that really there was very little damage. We saw a little bit of hippocampal damage. Sorry, this is actually, my apologies. This is the rat pups who actually underwent seizures that were normal and did not have any ischemia actually had no damage at all. This is a rat pup who underwent 30 minutes of ischemia without seizures and showed a little bit of hippocampal injury here with just H&E staining. You can see an eosinophilic stain there, and this is GFAP, and there was a little bit of abnormalities in the CA3 region of the hippocampus. When we added seizures to that, this is what happened. So normal rats having long seizures, just like Holmes found in the past, actually didn't show any particular neuropathologic injury. But when we induced short or brief periods of ischemia, they did show some mild injury in the CA3 region. When we added seizures on top of that, and this was actually a bit of a surprise to me, it dramatically increased the injury within the CA3 region of the brain, and actually in the CA1 region as well. And this is, again, the eosinophilic staining and GFAP staining. So clearly, in my mind, having seizures, if you have an underlying brain injury, and this happens to be particularly with ischemia, but is likely adaptable to things like sepsis or meningitis as well, is probably not a good thing. And this just graphically shows the increase in injury, which was predominantly in the hippocampus and not so much in the cortex. So the increase in injury seemed to be localized. We looked at the whole brain, and it seemed to be predominantly localized into the hippocampus, and that may be for several different reasons. So then we wanted to look at, well, why did this occur? Why did adding seizures on top of an ischemic injury cause increased damage, when on a normal brain it really didn't seem to cause damage at all? And so we did a bunch of measuring of various different enzymes and glycolytic components. This is blood glucose in those animals. This is measurement of that glucose, and we did a bunch of others, but I'm just emphasizing the ones that seem to matter at various different times. So in the control, at the end of hypoxic ischemia, prior to the time of seizure induction, and then during the seizure time. And if you pay attention just to these blue lines here, what you'll find is that during seizure induction, blood glucose levels went way down, but after seizures, there was recovery in those animals that didn't show any injury, but no recovery in those animals that did show the increase in injury. So for some reason, their blood glucose levels remained low, and it's probably because their cells were fighting hard to compensate. And I think that's true because when we looked at their energy levels, their ATP levels, during the time of seizure, again, or during the time of hypoxia, they go way down. During the time of seizure, they stay down. But in those animals who recovered and showed no additional brain damage in the white and yellow lines, their ATP or energy levels recovered, whereas those animals who showed the additional brain injury showed no recovery or a lack of complete recovery of their energy. And this was confirmed by Vannucci's lab before. So what we're thinking is that those animals who are recovering or who are unable to recover simply do not have enough nutritional substrate to do so. They're unable to recover their ATP, and so they have additional damage. And why does that occur? Well, if we remember what happens or what causes damage in the first place, it's that balance of excitation versus inhibition. During a seizure, as you can imagine, it's a hypermetabolic response. The patient or the animal in this case is seizuring away. They're using a lot of energy and a lot of fuel in the form of glucose and oxygen, both in their body and in their brain, and they're releasing glutamate into their synaptic cleft. And what happens under circumstances of ischemia is that the astrocyte, which is on the left here, or on your right, which normally takes up that glutamate, is unable to, because it too is injured, and it too is not getting any substrate, so it's unable to do its job of mopping up the glutamate which is normally there. And so this glutamate tends to increase and accumulate within the cell, and presumably with a lack of energy recovery and nutritional recovery causes that injury. Under normal circumstances, you'll recall that there was no injury if you just had seizures, and that's probably because these astrocytes are able to get their nutrition, and they're really able to mop up that excess glutamate that's being released into the synaptic cleft. And in fact, what we find if we measure glutamate in the brain of those seizuring animals, that is what happens. So these if you pay attention again to the blue dots for the moment, these are control values, and they're all relatively low. This is at the end of hypoxia ischemia, so in those animals that are not damaged, it stays relatively low. In those animals where there is damage, it goes high. There is some degree of recovery, but then during seizures, the glutamate really increases and stays elevated in those animals, in the brain of those animals who are ultimately injured, but not so in the animals who do not show any increase in injury. So clearly, at least in my mind, this experiment has shown me that seizures on top of an already compromised brain is not a good thing. And when Roberta asked the question the other day whether or not we should treat, my answer is actually pretty obvious. So what can we do about that? Well, we're probably doing something already, because standard of care, as most of us already know, is to look at hypothermia during severe asphyxia. And we went on to look at these animals under hypothermic circumstances. And this is a control where the animals, we lowered their temperature to normal. We didn't actually cause hypothermia, But you recall that those animals that were sieging actually became hyperthermic, and these would be them, and these are their brains, so they had a lot of damage. But if we controlled for the temperature and just kept them normothermic, didn't allow them to become hyperthermic, the amount of injury within their brain was reduced very substantially, and that there are two slides here because we did it early and we looked late to make sure that that effect was maintained over time. So right now we probably are doing some things just by virtue of the fact that we're looking at hypothermia as a means of protecting against ischemia. We probably are doing something to inhibit seizure production, although that's not entirely complete. And certainly in those babies who the severe babies who don't get so much protection, we probably need to look at additional anticonvulsant medication. And this is just what their brains looked like when we controlled for temperature. We recall it was quite significant injury in the CA3 region. When we controlled for temperature to normothermic circumstances, that injury was essentially resolved. So that's something that we are doing and probably can enhance on. So when I'm asked the question, should we be treating for neonatal seizures, clinical or otherwise, to be honest, my answer is yes, and that we should be fairly aggressive about it. And I'm sure we can have a big argument about it. I could see Roberta just jumping. And I guess I think so because it's even though there may be certainly some negative effects of the medications that we're using on overall development, I think the risk-benefit ratio in these children in particular who have hypoxia, ischemia, and severe injury, and the fact that their seizures usually last anywhere from 36 to 72 hours, so a brief period of time, would do well by being treated actually early on and almost in a prophylactic way. And hopefully that can stimulate a bit of conversation. So what else happens to these individuals? Well, in addition to seizures and temperature control, they also have some degree of hypoglycemia, or certainly are at risk for hypoglycemia. And again, another area of huge controversy. Does hypoglycemia in and of itself cause injury? And the answer, I think, is still not entirely clear. But does it cause injury when it's on top of an already compromised brain? Because let's face it, most of us are dealing not with normal babies, we're dealing with compromised babies. And so this is just a scan taken from a review that we did with Ken Poskett in Vancouver, just looking at what hypoglycemic brain injury looks like. And most individuals now agree that hypoglycemic injury looks quite a bit different than hypoxic ischemic injury. There tends to be a predilection for the posterior region of the brain and somewhat of a predilection for the white matter injury as well. But it's still unclear, quite honestly, whether hypoglycemia in and of itself will cause brain injury. And most clinical studies that are done in humans are done in an environment where babies are not really normal. So this is work done by Emily Tam and was just published a little while ago. And she looked at hypoglycemia in a group of individuals. But what I want to point out here is that these were not normal babies. These are babies who are already compromised by some fashion. And in her group, she had quite a number who are hypoxic ischemic, others who were intrauterine growth restricted, others who were infants of diabetic mothers, and several who were septic and others. And many of these babies, there was a significant correlation with umbilical artery acidosis, low pHs, and many of them, there was a significant correlation with encephalopathy, and as you can see here, also with neonatal seizures. So those who have shown that hypoglycemia is a contributor to injury, I think is entirely true. It fits with what I was previously indicating with respect to low blood sugars in association with seizures, and that being a potential for not only enhancing seizures, but the damage that occurs under those circumstances. So you can imagine a brain or a brain cell that's firing away and having a seizure, trying to recover its energy from the previous ischemic event and really starving for food. That's what it wants. It wants a bunch of food because that's the only way it can recapture its energy. And so if we deprive them of glucose or go with lower or accept lower blood sugars than the norm or even higher than that, we're probably doing a disservice to that baby. And why does this literature actually have any interest? Because it seems a little bit clear that we should not be doing that. But it comes from old literature in the adults that's tended to say that if we give a lot of sugar to adults who have had a stroke, that's a bad thing because it increases lactic acidosis. And there were many, many studies, and still are, that show that high glucose or higher than normal glucose in an adult who has stroke makes the stroke worse. But newborns are a different breed, a different species, a different animal. So we need to really not extrapolate what we tend to read, or some of us can read in the adult literature, and recognize that these babies need food, they need sugar, and we should, at the very least, in my opinion, sort of maintain that they have normal sugars, if not even a little bit on the high side, in those who are compromised by asphyxia and seizures. This is work done by Kornblath and Lucas and others, and just summarized here. If we just look at glucose levels and hypoglycemia in normal babies who are born, or presumed normal babies who have not been otherwise compromised, what they found is that the incidence of an abnormal outcome really increases dramatically if the hypoglycemia is prolonged and if it's recurrent. So the incidence increases pretty dramatically if you have greater than 5 episodes of hypoglycemia or days of hypoglycemia over the course of time, and similarly if it even lasts up to 3 to 4. So we wanted to look at this in our rats, and what we did, this is just a complicated slide that basically says nothing, and it's important. The reason I put it up here is that I wanted to emphasize that what we did was we injected rats with insulin over the course of an entire 24 hours, and my poor grad student was basically running a little neonatal intensive rat care group and had to follow these babies for the whole course. And so what they did was we induced we induced mild, moderate, and severe hypoglycemia using insulin for at least 24 to 36 hours in these rat pups. And then we did a whole bunch of behavioral studies, like a ton of them, and found nothing, actually. So even in babies who, or in our studies, who had relatively severe, which was less than 1 millimeter per deciliter of glucose, in the absence of any underlying injury, normal rats, they didn't actually show any behavioral abnormalities. But we looked pathologically, and this is just a normal control. This is a Floral Jade stain that shows dead or dying neurons and glia. And what we found was this singular area in the reticular activating system of these rats that tended to be damaged more only in the severe hypoglycemic group. So whereas my original thought was that profound hypoglycemia in a normal brain, in an otherwise normal brain, might be quite benign, I'm still a little bit skeptical about that. And even though we didn't find any behavioral abnormalities, we do have to remember that we're dealing, at least in my lab, with rats, and finding attention deficit disorder or autistic-like features in a rat pup is not the easiest thing in the world to do. So I guess my point here is that under severe hypoglycemic circumstances for prolonged periods of time, there probably is a risk for brain damage, and it's not something that we should take lightly and still, again, try and maintain normal glycemic levels. And then again, we looked at excitatory amino profile in these rats to see if there were any differences. And we did find some in aspartate, which is also an excitatory amino acid along with glutamate, lower levels of glutamine, which is a byproduct of glutamate, and slightly increased levels of alanine. And so there are changes that are occurring in the brain with severe hypoglycemia under these circumstances, and may compromise things. So I think the bottom line is hypoglycemia, probably not a good thing. On an already injured brain, definitely a bad thing, and we should pay attention to that as best we can. So just another case, premature rupture of membranes at 28 weeks, and we see that not infrequently. Early labor and contractions. Tocolytics were ineffective. It's a male who's born prematurely, so already a few strikes against them. Intubated and ventilated, and the baby gets surfactant therapy and goes into the nursery in one of our incubators and is ventilated. Now that baby is going to be exposed to a number of these complications that we talked about, and with ventilation, one of the things is alterations in oxygen levels and carbon dioxide. So what do we know about that? Well, what we know at this point is that high levels of oxygen are probably not as good as we thought they were. And certainly when I was a resident, our goal was 100% oxygen and 100% saturation, and that's what we did. And nowadays, things are a little bit smarter than that. But back then, we didn't know any better. And this is just a study that looked at hyperoxemia and whether or not there was an association with poor outcome. And this is severe hyperoxia or hypocapnia, and there was a significant association with poor outcome in both of these circumstances, and just in time regular breathing. So high levels of oxygen, low levels of carbon dioxide. There seems to be certainly an association with poor outcomes. This is a slide that looked at rats that were exposed to hyperoxic levels, and the higher the level of oxygen, the worse the outcome. And this is just a microscopic or histologic slide showing the increase in damage within the CA1 region of the brain when exposed to hyperoxia. So that's probably not a good thing, and I know all of you know that and are hopefully not doing that. But carbon dioxide is a little bit different, and at least in our nurseries, we're not really controlling for that to any great extent other than monitoring it, but we're not deliberately imposing hypocapnia or deliberately imposing hypercapnia. It's really based on how the child is being ventilated. And so maybe we should be paying a little bit more attention to that. This is one of the early studies that was done by Bob Vanucci, and I think one of the first to point out that carbon dioxide is probably important in the physiologic parameters and cerebral blood flow and how that can contribute to brain damage. So what they looked at was no carbon dioxide or no addition to carbon dioxide in the black and a damage score, and then they actually added carbon dioxide to the rebreathing mechanism of these little rat pups. And what they found is the white lines is where the animals did get a little bit more carbon dioxide. There was a shift in the damage score to the left. And what that meant was that the severely injured animals were shifting over to less severe injury. And so there was an improvement in outcome in those animals who were maintained with normal or high levels of carbon dioxide. And similarly, in the hypothermia group, that was a sub-analysis by Papasanel and published in 2011. They too found that the rate of death or disability was higher, this is the opposite, in those babies whose levels of carbon dioxide was actually higher than before. And recognize that when you're cooling a baby, you're also dampening the entire metabolic rate of that baby. And so those babies will not tend to be hypocapnic. They'll actually tend to be hypercapnic because their rate of ventilation will go down. And fortunately, actually, their rate of metabolism will go down, so their glucoses either stay normal or really go up. They don't tend to become hypoglycemic. So again, really an area that we have a lot of control over, and hopefully will take advantage of. So these little babies also, at least in our nursery, go into these lovely little incubators. Oftentimes we put a nice little saran wrap. We fold them up like a little sandwich and put saran wrap on them so that they don't lose any fluids. And a number of years ago, I was sort of wandering around the neonatal unit, and I was looking into the incubators of a number of our very premature babies, and I couldn't see them because it was raining inside the incubator. There was so much humidity that it was fogging up the entire thing, and I was asking the nurses, why are we doing that? And of course it was because so they don't get fluid loss, and I thought, wow, that's something that we do that's kind of interesting. I wonder if that has any effect on things. So we took our little rat pups and put them into incubators and changed the humidity and then exposed them to a hypoxic ischemic injury. So this is a simple slide showing brain damage on the left. The higher it is, the worse it is, and humidity on the x-axis here. This is low humidity. This is middle, around 60%. This is about 30%, and this is about 90% humidity. And lo and behold, what we found was that in the low humidity, babies actually did quite a bit better in terms of their brain damage. And while that sounds a little bit weird, in our nurseries, the humidity is just controlled by a central switch. Nobody does anything in our hospitals. And so the humidity in Vancouver, which is on the west coast, is dramatically different than the humidity in the prairies, which is usually pretty low. And in the wintertime, it changes compared to the summertime. Now, in the incubators and premature babies, we change that independently. But my point here is that even in term babies, we may want to pay a little bit of attention to what our humidity levels are and what they are in the newborn infants. So while recognizing that we need to maintain their fluid status and ensure that they're not becoming overly dry and maintaining their nutrition, we need to recognize that when we do things like make it rain in an incubator, it may not be entirely benign, and that we need to pay attention to that. So I thought that was all due to temperature, because if you increase the humidity, it always feels a little warmer to me, and that seemed natural. But what we decided to do was to look at that same experiment, but then control for temperature. And what we did was we took those same babies, and then in one group we had the high temperature but low humidity, so we controlled for that. And in the other group we had high humidity but low temperature. And what we found was that actually that didn't make any difference. So even in the low temperature group, if they had high humidity, they still got worse. Their brain damage was still worse than in those in the low humidity, even though their temperature was a little bit higher. So there's something about how water and humidity is affecting the brain versus that is independent of temperature in our hands, and that is something that we should look at it probably as an independent factor even of temperature. So finally, I just want to touch on infection. This is a slide from yesterday, and you'll recall that this whole inflammatory response occurs over a long period of time, probably 3 months and maybe even longer, as long as 7 months. And that too is something we can do something about. We know that chorioamnionitis, whether clinical or subclinical, certainly with prematurity, but also in term infants, adds to the risk for cerebral palsy. This is a systematic review by Yvonne Wu, and she showed, as I said, that clinical chorioamnitis increases the risk by 4 times, and in histologic by 1.5 to 2 times. And this is an accumulation of data from various groups that all show that the association of chorioamnionitis with cerebral palsy or worse outcome. So in spite of the fact that there remains some controversy, it's probably a real phenomenon. Steve Miller very wisely looked at premature babies who didn't have chorioamnionitis because one of his earlier studies actually didn't find an association with chorioamnionitis, but he looked at postnatal infection. So premature babies who are in the nursery but who have some signs of infection, whether it's clinical signs of infection without a positive culture, fever without positive cultures, or positive cultures. And again, he found a very significant association of multiple infections with an increased risk for CP, and he also showed alterations of that more recently with MRI changes in various regions of the brain. So clearly, whether it's an inflammatory process or a true infectious process, there's something that is increasing the risk for cerebral palsy. And this has been proven in the lab as well. This is a number of studies accumulated here, one by Sabir in Quebec, where they've actually used LPS, and this is a group, this is MRI scans of a pregnant rat. These white areas here are actually the placentas and controls, and that indicates that they're getting perfusion. In the LPS babies, they're dark, indicating that the perfusion to the placentas under an inflammatory process is actually diminished. And so that's an indication that there probably is vascular compromise from the placenta under circumstances of chorioamnionitis. This is work done by Pierre in Paris, as you all know, again looking at an LPS model in rat pups and showing that the amount of myelin in this control when a baby or a newborn rat pup is exposed to LPS or infection, the extent of myelination is dramatically diminished, and that's shown graphically in this lower slide. And this is work done in our lab where we've created an LPS model in our rats as well. And this is just behavioral work done where the LPS has actually worsened the developmental behavior of these rats. And I'll talk a bit more about this later, but we can provide a natural health product that will improve or prevent that outcome. So there certainly are many things that we can do to try and prevent that. And I think Linda alluded to the fact that there was a correlation with antibiotics and a reduction in their level of cerebral palsy. And this goes along with that. This is Arvin's group, and they looked at minocycline, which is a known antibiotic and anti-inflammatory. And they looked at that 7-day rat pup model, and they looked at giving the antibiotic before and after the insult. This is control animals where they have a very severe lesion on the ipsilateral side to the ligation. Minocycline actually almost diminished that completely. And this is shown here as well when they give the minocycline immediately after the insult, but if they delay that, the effect is really markedly diminished. So giving it before or immediately after the insult seems to help. If you wait a long time, you've kind of lost the opportunity. And this is work with doxycycline, which is a little bit more easy to use in newborns because it has less side effects than some of the other cyclin antibiotics. Work done by Catherine Todd at our university a number of years ago, and she too looked at a number of groups. The important thing here is these are controls that were not given any doxycycline, and these are various doses of doxycycline, and all of them seem to get improved outcome when given the antibiotic before the injury. So I just, to conclude, I want to say that really there are a number of things that we can do that we already know about and that we already know contribute to injury, and that we probably should pay attention to, just like ABCs when we're resuscitating a baby, in terms of ensuring better outcome, and may have a much more dramatic effect on overall outcome than some of the fancy things that we're starting to look at. Maintaining good thermoregulation at the appropriate time is important. Probably controlling for seizures early on, and I would go as far to say as being prophylactic about it, is not a bad idea. Glucose concentrations are very important, and I think low blood glucose is never a good idea in a newborn, and we should at least maintain them at normal levels or even a little bit high. Watching what our blood gases are showing us and trying to prevent hypocapnia under the right circumstances, also a good idea. Being cognizant of what the humidity is. If it's raining in the incubator, maybe we should figure out why that's the case and whether or not we need to be as excessive as that, and preventing infection. And I added this yesterday because we can eliminate all of that if we just have NIC in our group and ensure that NIDCAP is working. So I'll just end there with a couple of conclusions, which I've already said. Complex problem throughout pregnancy, and we need to just pay real close attention to physiologic monitoring. So thank you, and I'll take any questions if there are any.
Thank you very much. I have two questions about the hypocapnia. One is in a ventilated baby. In our unit, we are quite aggressive in avoiding hypocapnia, and we always teach our residents that if they have a ventilated baby and the CO2 is below 30, they have to adjust the ventilator setting quite aggressively and do a repeat blood gas after 15 to 30 minutes. So my question is, what's the policy in your unit, and what would you consider a safe limit for the CO2? And my second question is about a spontaneously breathing baby, because some babies have a metabolic acidosis, and they try to compensate and have their CO2 level lowered. We have actually, Linda, we have some babies who were spontaneously breathing and developed a cystic PVL. We tend to treat this baby with sodium bicarb, which is also quite controversial, perhaps. So could you comment on that, please?
Yeah. So I believe that the policy in our unit... Oh, sorry. So excellent question. I don't know if I have the exact answers for you because I'm a neurologist, not a neonatologist, and so they don't let me in on the policy stuff. But I believe the policy is similar to what you're describing in your unit, is that we try and not maintain CO2s less than 30 anymore. And I think we have to, again, sort of go back to basics and think about why that's a problem. So the presumed issue with hypocapnia is really related to cerebral blood flow, because if you hyperventilate and blow off all your CO2, you get a bit of vasoconstriction. Now, how true is that in a baby who's sick or asphyxiated? Because the alternative that we know from studies many years ago, that in an asphyxiated baby you tend to lose autoregulation. So my suspicion is that there's regional variability within the brain. And those areas that are compromised by an injury may have lost autoregulation, but those areas that are preserved may have maintained their autoregulation. So to some extent, I think we need to balance that idea and probably start to look more specifically with NIRS or other methods to see exactly what's going on in the brain and whether or not there's regional variability or whether there's global variability. So in answer to that question, I think 30 is not unreasonable. My suspicion is it's probably still a little bit low, to be honest, because really high CO2, really, why is that a problem? It's only a problem, I think, if you're concerned about an IVH or a very premature baby where you're going to get real big fluxes in your pulsatility index, so to speak, and you're worried about an interventricular hemorrhage. So I think balancing that and treating sort of each baby kind of individually in that thought process is important. So I think 30 is good, but if you're not concerned about higher levels in that baby, I don't see why you might not go higher. In the spontaneously breathing baby, that's a real tricky issue because, are you going to, in a baby who's breathing and otherwise doing well, become invasive? And the studies, to my knowledge, haven't been done about sort of rebreathing or actually adding CO2, but I suspect we'll go there to some extent. And again, I don't really see a big issue with that if it's done on a very individualized baby, individualistically. So you don't want to take, a 24-week baby who has a high risk of an IVH and all of a sudden give them a lot of CO2 so their blood flow goes way through the roof. You want to be cognizant of that. I don't know if that helped or not, but.
I'm not sure I could pick
Just a moment. We are with the taping and everything.
It doesn't matter if you're the boss. If you don't have the microphone, it doesn't matter.
On the same lines, how is the humidity affecting, how does that affect the brain injury?
Yeah, good question. I guess in our lab, it's probably not a good thing from what we're seeing, and it seems to be independent of temperature. So, I started doing those studies because I was curious, and I think someone alluded to the fact that we tend to do a lot of things to babies without really proving or disproving that it's very helpful. And the humidity, you'd think is kind of a benign aspect, but with all the talk about thermoregulation and making sure that temperatures are either on the cool side or warm side, we decided to look at that. So, I would take that as an observation. I wouldn't necessarily change what you're doing in your units, other than to say that we need to be cognizant of it. So in our unit, again, what tends to happen is that we have a premature baby. Everybody's worried that the baby's going to, lose fluids and dry out. So we wrap them up in saran wrap and we increase the humidity to a rainforest, essentially. And then we kind of walk away and, hope that the baby's doing okay. And my point is to continuously ask ourselves, why are we doing that? Can we replenish the fluids simply by intravenous or by gavage feeding or however the baby's getting fluids otherwise? And is it necessary to increase the humidity to such extents, to such an extent where it's very high and maybe contributing to injury? I guess that's my thing. In the old days when we used to give 100% oxygen, that was the knee-jerk response. Babies are coming out, they're hypoxic. Oh, we better give them everything, give them maximum oxygen. And maybe this is a similar kind of knee-jerk response where we're giving lots of humidity, but not asking the question, is that really necessary? Or maybe just a little bit humidity is necessary. Do you know what I mean?
This was my question.
Yeah. No, it's an interesting observation. We're having interesting troubles publishing it, but yeah. What can I tell you? Sorry, where was that?
Just one comment on the CO2. To my personal opinion, having a ventilated baby, and if we have the choice to alter the ventilation, 30 is not an option. I would say 34 in a ventilated baby. It's much more complicated in the spontaneously breathing, and we do a lot of CPAP in Europe. This is more a problem, I think. But I think if we have a baby on the ventilation, we should try to optimize as much as possible. And everything under 34 for my residents would be not a choice. Mm-hmm. One question to the hyper or hypoglycemia. Hypoglycemia, it's clear, we add just sugar. But very often we see hyperglycemia. But to my imagination is that the cell is there is starving because of the insulin resistance. So the blood sugar is going up.
Mm-hmm.
We reduce the amount of sugar given to the baby, and we reduce it to a certain amount, but it's still high. When do you start insulin? Don't you think that the cell behind the high blood sugar is still starving? Could you please comment on that? So that there is a relative hypoglycemia to the cell.
Mm-hmm.
And where is the point to start insulin, or what is the point just to reduce the amount of sugar delivered to the baby?
Right. So I think that, again, that's a good question. So just to go back to your carbon dioxide question or point again, I think, again, if we start, and maybe relating to what you asked earlier, if we just look at numbers like 30 or 34 or 40 or whatever we decide, that's sort of something in isolation. And for an individual baby, it may not matter, because what really we're worried about, I think, is the perfusion to that baby's brain, either regionally or globally. So if, for example, we have a baby who is being ventilated and they're 28 weeks, but you're also having problems with maintaining mean arterial blood pressure, or they're having many episodes of bradycardia and alterations in their blood pressure, that's not a baby who you want to keep on a, in my opinion, on a low carbon dioxide, whether it's 30 or 34. You may actually want it higher because you're already getting a reduction in cerebral perfusion pressure just based on the baby's systemic blood pressure. So I think the point about what we're all trying to say here is that these numbers are kind of interesting, but they're not the only thing. All of them have a ripple effect, and all of them have, for every action, there's an equal and opposite reaction. So I would say that in those responses, teaching the residents that 34 or 30 or 40 is even the number to look at is not really the answer. It's, let's look at this baby in its entirety. What's its blood pressure? How is it ventilating? Are we able to look at cerebral perfusion pressure in some way with either NIRS, and then take that into account when we're adjusting some of these other physiologic parameters. Similarly with glucose, again, does high glucose cause problems? Right. The answer is it depends under what circumstances. So if you have a very high glucose and you're getting osmotic diuresis and the baby is becoming dehydrated, that may be a problem if you're unable to maintain adequate fluids and unable to keep up that way. But beyond that, is it really causing a problem? I'm not sure that would be the case. So I think we need to take it in context. In our unit, many of the neonatologists would give insulin to lower that, and I sort of cringe a little bit because, those can be, oftentimes we're getting very fluctuating glucose levels. Sometimes they're dropping below normal because insulin is a very erratic kind of thing, and when you've already got insulin resistance, you can cause all kinds of havoc. So I think we need to take them individually and ask the question is, just because a number is abnormal, is that causing a problem? Why is it causing a problem? And then try and address it from that perspective. And these parameters, I'm just trying to point out, are things that we actually control. We as physicians, as intensive care people are in control of. The poor babies, they're just lying there and hoping for the best. So.
Just a comment, there was last year a study from Ulrike Aden from Stockholm in pediatrics about high glucose levels in preterm babies and increased white matter injury. So
it would be interesting. I'll have to look at that and see what the other aspects of that are. But and there may be an osmotic effect of that. It's hard to know. Thank you.